Good afternoon. For those who don't know me, I'm Diana Curdy, and I'm honored to serve as the chair of the Board of Trustees of the University of Rochester Medical Center. And it's my pleasure to welcome you to the board's annual program. We are especially delighted to have with us this year Dr. David B. Nash, who is both a renowned health expert and a University of Rochester medical student alumnus. Yay, yay, double yay. W. More than 40 years ago, in a personal statement that accompanied his application to the School of Medicine and Dentistry, Dr. Nash professed his dedication to helping meet the health challenges of Americans in the years ahead. Little did he know that that would include a global pandemic. Much has transpired in that journey, from prospective medical student to one of modern healthcare's most influential people in healthcare, to his latest achievement as co-author of the new book, How COVID Crashed the System, A Guide to Fixing American Healthcare. Dr. Nash has emerged as one of the world's most respected experts on healthcare accountability, quality, and leadership. His current roles include founding dean emeritus and the Dr. Raymond C. and Doris N. Grandon Professor of Health Policy at the Jefferson College of Population Health in Philadelphia. He has also served many years in governance roles focused on quality, safety, and public reporting of outcomes. Dr. Nash's work is well known through his frequent public and media appearances and many publications. A distinguished alumnus, he holds both a medical degree and honorary doctorate from the University of Rochester. He also holds a bachelor's degree in economics from Vassar College, an MBA in health administration from the Wharton School at the University of Pennsylvania, and honorary degrees from Salus University of Philadelphia and Geisinger Commonwealth School of Medicine. Dr. Nash brings a wealth of knowledge and experience to analyzing the COVID crises, discerning its lessons, and recommending how to apply them in shaping the future of our healthcare system. We are just delighted to have him here with us today to share his wisdom and his insight. Please join me in giving him a warm Rochester welcome.
Thank you so much. All right. And warm in Rochester, that's an important thing. Yeah. So, Diana, thank you so much, and great to see Dr. Taubman and so many of my friends and former students in the audience. That's how you know you're really old. You have no idea what a great feeling it is to be standing here to a board education program instead of sitting in the third row scribbling and taking notes. It's a much better position to be in. You also can't appreciate that coming from Vassar College as an economics major 45 years ago to the University of Rochester top 10 research medical school was not exactly an easy transition. Let's just say I was not a stellar first and second year student, but became a much better student in the third and fourth years. Also, it's really important to share with you that because of Rochester, I met my physician wife, and we're celebrating anniversary 42. How did that happen? So, Dean Lowell Orbison, ring a bell. I was on the medical student government, and Dean Orbison paid for me to go to New York City to an American Medical Student Association meeting at Mount Sinai Medical School. I was staying in New York, took the bus to Mount Sinai, got up there late. I saw a very cute brunette sitting towards the back, sat down next to her. The rest is history. So what I tell medical students today is be careful when you go to a medical student convention. You never know what might happen. So I'm truly, truly honored to be here. So, what can we say about post-COVID life and all of that? So here's what I'd like to do. I'm going to divide my time with you into 3 parts. So part 1, a little bit of a downer. how do we get in the jam we're in? What's wrong? I think review for most of the board members for sure, and certainly for our clinical colleagues. But I think we have to sort of have a level playing field as to what exactly happened and why are we in the jam we're in today. Second part of my time together will be a little bit about population health. And as your board chair noted, I had the privilege of being the founding dean of America's first College of Population Health. We opened our doors in 2009, 2 years, a year and a half before Obamacare. What was population health? I spent the first 2 years of my deanship on my own campus trying to explain to everybody what exactly is population health anyway. And then the third part of our time will be, I'm going to look into my cloudy crystal ball and give you my vision of the future. So as a good internist, one more time, let's review. Part one, how do we get in this jam? Part two, population health, value-based care. What can the University of Rochester Medical Center anticipate? And then part three, we'll look into the future. Certainly, let's also just take a moment. Very sorry about those bills. I was watching. The Eagles, of course, we're on cruise control. We're going to beat those 49ers, and then we're going to take on whoever's left, and we're going to beat them too. So you heard it here first. I hope you'll be watching on Sunday, February 12th, because we surely will be as well. Okay, so let me get the technology to work. You'll be very disappointed. Okay, so let's go back to this. So first, just some fun things to get you in the mood. Somebody sent me this wonderful slide outside a church, thou shalt wear a mask, and if you look carefully, it's in Hygienesis 2020. Of course, there is no such book in the Bible, but I thought you'd enjoy seeing this anyway. Okay, I'm going to just say one word about Jefferson. And so I left Rochester in 1981. I'd already been married in medical school, so Esther and I moved to Philadelphia, where she was originally from. There are lots of hospitals in Philadelphia, so when you have a two-doctor couple, one of the key things was finding a place where we could both go. We're so old, we matched outside of the match, and we ended up at a University of Pennsylvania hospital called the Graduate Hospital, downtown in a rock'em sock'em, knife and gum club kind of place. We were very fortunate to be on call together for most of year one, less in year two, and never in year three. But how many people can say they survived residency and still came out married on the other end? I mean, that was a major accomplishment. Then I spent 5 years on the Penn campus, as Diana mentioned, in part as a Robert Wood Johnson Clinical Scholar going into the business school. And I was very fortunate to get recruited to Jefferson in January of 1990, where I have been ever since. So you're looking at a walking, talking dinosaur, because who is in one place in academic medicine for 33 years? And tomorrow I have probably, I hope, my last contract negotiation with our president. So I want you to wish me luck and send me good vibrations for tomorrow. Can we ask for that? Yes? Okay. So this is our office at the corner of 9th and Walnut. The new dean, who I recruited 6 years ago, he and I have offices as far apart as possible on the 10th floor of this building, because it's not easy for him to have the old guy still around. So I took a corner office as far away as possible, and I said to him, Billy, when you need me, I'll be here. But otherwise, I won't call you, and you certainly, I hope, won't call me. And that's how we've gotten along in the last 3 years since I stepped down as dean. Last night at dinner, we chatted a little bit, 2 seconds about Jefferson. We're now 18 hospitals, $9.5 billion in revenue delivery system. Our university is 8,000 students, 10 colleges, and we have one leader. So we have a university president, a health system president, and they both report to one who we call enterprise CEO, who's brand new and has been on the job for 3 months. So wish him a lot of luck. So part one. So colleagues, in 2017, American life expectancy was in the wrong direction. 2017, 6 years ago. Because of the four horses of the apocalypse, suicide, opioid abuse, alcoholism, and depression, among other issues. For the first time since the Second World War, American life expectancy had gone down. My baby boomer wife and I, and our millennial children, my thinking was, well, how could this be that our millennial children could potentially have a shorter lifespan than the boss and me? Made no sense. So further evaluation of all this, and this is of course all pre-COVID, got me thinking about the issues when we opened the doors to our school in 2009, as I noted. What's driving a worsening health in our population? These were some of the things that I think were very important to me. So I went around looking at what's out there in the literature. Perhaps you've read some of these great books from some of our colleagues. Bobby Pearl, former chief medical officer at Kaiser Permanente. Of course, you all recognize Zeke Emanuel, one of the co-authors of Obamacare, now at the University of Pennsylvania. Still got a very big mouth. Elizabeth Rosenthal, New York Times reporter, but was an emergency room physician. So all of these books were by way of background learning to say, you know, what's going on and why are we seeing life expectancy going in the reverse direction? And then, of course, COVID. I've got to take a time out because my phone is ringing and I hear it in my Bluetooth hearing aids. Is that the craziest thing you've ever heard? So let that go. Okay. So let's just take a moment, and here we are, of course, front page Sunday New York Times, 1 million dead, a nation's immeasurable grief. So here in part one of our time together, you know, how'd this happen? In the world's richest country, how did we have the highest death rate per capita? Why was it that we were overwhelmed, that our public health system, not so much our delivery system, but our public health infrastructure essentially collapsed? So Charles Wolfirth, my co-author, is an award-winning science author, lives in Princeton, New Jersey, not too far from my home in Philadelphia. I had met him pre-COVID at a science conference, details not important, but in May of 2020, we're 4 months into it, Charles called me and said, you know, I know about your work and I want to give a voice to your work for a broader audience. Would you write a book with me? Well, who could turn down an offer like that? So that began our 18-month, every other week, 90-minute Zoom call. 18 months, every other week, 90-minute Zoom call that Charles recorded. I did the research with my medical student research assistant. I came up with the topics. He recorded the call, and by magic, turned our recorded sessions into prose, and hence the book. We could not have imagined when we started that we would hit 1 million dead. So we're going to talk about how did this happen and why, despite spending $4 trillion a year, 20% of the GDP, why America had the highest death rate per capita. So you know some of this story, of course. If you look around the world, here's a New York Times piece about Australia. Here's a similar piece about Norway. What are the common threads? Well, the common threads are pretty basic. Let's just review them together. In countries where there was trust in government, I'll let that hang in the air for a moment, and total public accountability and transparency, meaning as Prime Minister, I'm going to say to you, I don't have all the answers, I'm going to make mistakes, and I need your help to get the country through this crisis. Can you imagine, colleagues, if our own leaders had just said those few sentences? I don't have all the answers. I'm going to listen to the best available experts. I need your help to cooperate and collaborate so we can get through this together. Oh, and I'll keep you fully apprised of the good and the bad news. And we're going to learn from what other countries are doing. And I've got your back. I hope you have mine. Well, essentially, that's what Australia and New Zealand and Israel and Norway and a slew of other developed countries, why their per capita death rate was a fraction of what ours was. And of course, you could argue Australia an island nation, and we're a very big, very heterogeneous, very politically fractured country, of course, but these were some of the issues that Charles and I were dealing with. Here's from our own scientific literature, we also learned what? Well, annual spending on that public health infrastructure, about $400 per person per year in 2019 dollars. Healthcare delivery, healthcare services spending in 2019 per person, every single person, including children in the United States, $10,000. $400, $10,000. Anybody surprised that it crushed the public health system, that even in our great city of Philadelphia, one leader didn't know what the other was doing, our electronic records couldn't connect, we could barely get people to sit in a room together, and on and on. So another aspect of this is the social issues that COVID exacerbated. Sad things. Taking that alcoholism, depression, opioid abuse, and suicide to levels never seen before, in addition to terrible things like domestic violence and all the other social ills that a big country like ours has. So with a great audience like this, it's sad for me to be in front of you to say, what the heck happened? And how could we prevent it from happening potentially next time? And what's the role of public health and the healthcare delivery system in a country that has such political challenges? So we couldn't answer every question in the book, but we started to ponder what all of this meant, and could we organize it in a way that would appeal to a general audience instead of just saying, oh, not COVID again, but not about the disease itself, but its impact on the nation and what we could do to do a better job next time. So hence, how COVID crashed the system. I'm incredibly proud to tell you a few things. First, all the revenue from the book goes to the Jefferson College of Population Health. So, Madam Chair, thank you. And your $2 per copy makes a big difference, very important. The 1,000 copies we've sold every month since the book came out, just after Labor Day weekend, broke all records for my publisher in Maryland, Roman and Littlefield. So I think there's still a hunger for some answers, and maybe even a hunger, if you would, for some guidance as to what we might do, and at least maybe have a conversation. Today, with Maura Dow's wonderful help, I spoke with Evan Dawson, the NPR in your marketplace. We spent an hour that went by seemingly in 5 minutes, and he asked some spectacularly detailed questions, reading quotes from the book. I already have email from people who were listening to us. So it's accomplishing the goal that Charles and I set out, which was, could we have a conversation about how we might do a better job? So let's get a little history and context. That's the lead up to why we did the book. Now, you could read along with me here. All integrated delivery systems like the U of R and Jefferson Health are accountable to the public for their degree of success. If this initiative isn't taken by the people in this room, it will be taken by the lay public. So if you look at the lower right here, this is an exact citation from the inaugural meeting of the American College of Surgeons, pretty remarkable coming from an internist perspective, over 100 years ago, at the formative meeting that created the American College of Surgeons at the Waldorf Astoria Hotel on Park Avenue in New York City during World War I. And I just want you to focus on two words here, and they're, of course, accountability and transparency. That's really what these prescient surgeons were thinking about. And what they were really saying, and of course no women in this group at that time, they were saying to one another, hey guys, we are responsible and accountable. And if we don't do it, somebody else will. And I want you to keep that in the back of your mind as we get to the part 3 of our time together. So what's the current marketplace pre-COVID? What sorts of things were happening before March of 2020? Well, maybe not so much in the Rochester region, but where I come from in Philadelphia, let me give you some sense of what was happening. When I got to Jefferson in 1990, we had 1.5 hospitals. And that was true through 2000, through 2010, through 2018, and from 2018 to 2023, we went to 18 hospitals. And this is mirrored nationally in major groups like Ascension and all the others you're all very familiar with. Oh, and similarly for the for-profit hospitals, Tenet, Hospital Corporation of America. So while hospitals were merging to be able to tackle insurance companies and get economies of scale, none of which has been proven, by the way, the issue is that the New York Times and many other smart people were saying, well, wait a minute, maybe bigger isn't so much better. And I just have some slides to show you that. This is the New England Journal of Medicine famous evaluation of, and very important since we have the board here, from a quality perspective, does getting bigger mean you're doing a better job? Well, we'll show you some stuff later that's pretty sobering. Great to hear about your outstanding Joint Commission outcome. This is not true all over the country. Let me just leave it at that. And we have some real challenges. So in the pre-COVID marketplace, this rush to partner was a key characteristic of our market. For some, this was helpful when COVID hit, and for others, a disaster in terms of communication, connectivity, sharing resources, sharing information about patients, and all the rest. And even Modern Healthcare had a cover story. I'm sure you've seen aspects of this. The real issue pre-COVID was we had starved the public health infrastructure. I already told you $400 per person versus $10,000. Anybody surprised, therefore, that we couldn't even remember or figure out in Philadelphia with 5 medical schools, 2 of which are walking distance from one another, and those 2 are the 2 largest private medical schools in America. Sidney Kimmel Medical College. If I give you $160 million, will you name the school after me? Because that's what Sidney Kimmel did. Yes. So Sidney Kimmel Medical College and Drexel University College of Medicine, walking distance from one another together, are the 2 largest private schools for medicine in the country. More about Philadelphia in a moment. So we were ill-equipped because of structural inadequacies. Then we got to go a little deeper. And hang in there with me, because some of this, if you're not a clinician, is nuanced, and if you're a doctor, you're going to be annoyed, but it's okay. So this is a Business Week cover story magazine, right? No longer, this is now Bloomberg Business, but Business Week you recognize. And get a load of that cover. It's kind of obnoxious, isn't it? A doctor on a roulette wheel, medical guesswork, we don't know what we're doing. Well, colleagues, the doors are closed, yes. We have no secret visitors, no members of the press, hopefully. So here's the secret. 18% of the time, at the bedside, wherever we are, we have solid evidence to support what we're doing, plus or minus 2%. Let me translate. 1 out of 5 times, we know exactly what we ought to do. Now, if you've ever been a patient, you know exactly what I'm talking about. And if you're honest as a clinician and you look in the mirror and you self-evaluate, you understand exactly what this cover story is all about. And if you own a business and you have pay for health care for your employees, you know that you're paying for massive variation in what we do. So the good news is if you go to the U of R or Jefferson, you know you're going to get great care. Everywhere else, we can't make that promise, right? And that's tongue-in-cheek, of course, but variation is our principal challenge. Now, I listened closely to the finances at that board meeting, having been a board member for 20 years in 2 separate systems, so I can translate board speak. You will never get out of the jam we're in based on volume. You know that, right, Madam Chair? So you got only one way to go, and that's reduce unexplained variation and be efficient and get doctors to work together. Well, you've got Mike Rotondo to do that, because his job moving forward is going to be tougher than ever because of what we come to call unexplained variation, which is a polite way of saying, I went to Strong Memorial Hospital. I learned the right way. Your way is wrong. What we really need is proof of that moving forward. So that's an underlying challenge in the system. Another underlying challenge, and I regret that Mrs. Dr. Nash and I are now regular readers of the AARP Bulletin, along with 56 million other Americans. So, doctors say, skip these tests. So we don't have time today, but basically there's incredible overutilization, inappropriate utilization. Let's just tell one story, because grown-ups remember stories. So when my late father-in-law was still alive, and he went for his Obamacare annual wellness visit. Roughly at that time, he was 83 years old. And his Ivy League medical school trained primary care doctor got a PSA, a prostate-specific antigen, on Grandpa Harry at age 83. Of course, at that time, his prostate was the size of an underinflated basketball. And so, colleagues, his PSA was very high, and everybody's nodding. The doctors know exactly what happens from here on. So off Grandpa Harry went for surgery to reduce the size of his prostate. Unnecessary, crazy stuff that Esther, my wife, his daughter, the doctor, her kid sister, also a doctor, and I had to prevent Grandpa Harry from going down the rabbit hole of overutilization. I'm confident at this very moment, at the end of the workday across the 18 Jefferson hospitals, hundreds, if not thousands, of blood tests were done for no discernible reason that doesn't change the care the patients are getting. That is the sad reality. Now, of course, we have 2,000 house officers across 18 hospitals and 100 accredited programs, so that's all part of what we do every day, similar to here. So the balance between what do we need to do to teach and become great doctors versus the balance between we got to be efficient and figure out the best way, the evidence-based way, this is part of the underlying challenge for the future. And we'll come back to all that. So this unexplained variation, this was background music before COVID. This was driving to 20% of the GDP. So COVID shined a bright light on this and some other more socially related problems. The other issue, of course, even in this week's New England Journal, the January 12th issue, about quality and safety. Now, everywhere but the U of R and Jefferson, this is a really big problem. And you all know, sadly, that many people are hurt. Preventable error is a big problem. And over 400,000 people per year now suffer some untoward event, a permanent injury, even death, from preventable medical mistakes. So today, if you look at the epidemiology of illness in our country, heart disease, #1 killer, cancer, COVID, now #3, and #4, I know it's hard to internalize, #4 is preventable medical mistakes. Pre-COVID, post-COVID. Heart disease, cancer, COVID, preventable error. And if you don't believe me, just go to the most recent New England Journal of Medicine and see the amazing redo of a study that was first published nearly 30 years ago. So this sort of illustrates the problem, a fantastic Time magazine cover story. What doctors hate about hospitals? I won't ask you to raise your hand and tell me, but I'll give you the answer up front. Of course, anybody who's self-aware and has a high social IQ knows what the doctors hate about hospitals pretty clearly, being a patient in one. Because we know what can go wrong. And of course, there's an unwritten rule if you're a doctor or a family member of a doctor and you're exposed to the system. I mean, we won't go there because it's complicated. But basically, medical error is still an incredibly important part of what we need to work on. So I told you that part 1 was pretty sobering, and we haven't even finished all the details. So during COVID, the good news was that, like you, we had an incident command center, and we were issuing new guidelines every day. We were bringing in information. We were doing what people like Bob Panzer had been thinking about for 30 years. We were doing daily process improvement, daily closure of the loop. We even coined a phrase, this was the incident command culture. So the question is, it took a global pandemic to create an incident command culture where every day we were open to, what are you doing on 3 North versus 3 South, because the mortality difference is remarkable and statistically significant. Can we learn from that? Or calling our colleagues at other institutions worldwide or online day and night to learn what was working and what wasn't. And the openness and the willingness to adopt new things and to close that feedback loop in our jargon of quality improvement was a fantastically positive aspect of an otherwise global disaster. And I won't tell you about the wrong kidney being transplanted during COVID at our colleague hospital at the University of Cleveland and other places. This is still an issue that we need to think about. So let's summarize. $4 trillion a year. Most experts agree that $1 trillion of that, 1/4 of that total spending, probably is of no value and potentially dangerous. So let me just stop for a second and ask you, do you know another industry that faces this sort of challenge? If you do, please inform me. Or another industry that spends $4 trillion a year, and from a life expectancy perspective worldwide, we're in reverse gear. In other words, not getting a return on our investment. All of this pre-COVID. Had nothing to do with COVID, quite frankly. So this waste is characterized in many different ways. Clinical waste, that's pretty much what I just described to you. Overutilization, inappropriate testing, unexplained variation. Then there's operational waste. That's when you go home and you're still working on the epic computer for 2 hours at home because you had no time during the day, and related issues. So this is the blueprint of what Jefferson Health has to do to become more efficient, is to tackle these different categories of waste. If you want to summarize, it sort of looks like this: $1 trillion of waste. Herein, when we get to part 3, herein lies the secret in a post-COVID world of how we might dig out of this hole. Also, let me move over here for emphasis. This is of great interest to a lot of folks from the private equity and venture capital world. Why? Well, they see a $4 trillion industry with $1 trillion of waste. What do they see? They see an opportunity to make a margin. If you make a 2% margin on $1 trillion, you're doing pretty good. So they're all over us to try to figure out what can we do in our industry to be more efficient, follow practice guidelines, coordinate care, drive care to the home. And again, I know you're interested in many aspects of this, as is Jefferson. We have a modest investment fund now where we're looking at some of these things. We're going to have to find new partners to become more efficient. Big topic for another time. Let's summarize. As my wife says, part 1 of the book, when she finally read it a month after it came out, that's supposed to be a joke. You guys didn't get it, right? So 42 years, she said, maybe I should read the book. I said, well, honey, that would be wonderful. And there we are at night, and we have a rule in our family. One of the ways we got to year 42, no new topics after 10 p.m. It's an excellent practice. I'd recommend it. So at 9:45 p.m., Esther says, the first half of this book is like a Johnny Downer. I said, well, honey, if you hang in there, I promise part 2 will be better. Okay, which she did. So part 1, let's review. $4 trillion, $1 trillion of no value, medical error, the 4 horses of the apocalypse. It's depressing. Then let's add on top of that a global pandemic, crushing the public health system. Sure, there's heroism. There was heroism at the U of R, just like there was at Jefferson. And 1 year later, those heroic house officers in our city had to change out of their scrubs before they got on the subway to go home so they wouldn't be accosted by people saying, all you doctors making us wear those masks, making us take those vaccines, you guys are part of the problem, not the solution. Remember that? The clanging of all the pots and pans? We did that in Philadelphia every night at 7 o'clock. It lasted about a year. Then they wanted to take those pots and pans and hit the doctors and nurses over the head with the pots and pans. So not heroism. What we needed was humanism, better communication, better accountability, greater discussion, less political fractionation, and all the rest. Okay, so let's transition into the second part of our time together, right on schedule. So let me first show you this. I did not make this up. This is on the door of the high school whose track I go running on in suburban Philadelphia. This gives me like an existential crisis. It's not an entrance or an exit. It's something like a high school principal would put on a door just to cause, what is it then if it's not an exit or an entrance? Anyway, okay, part 2. So we could summarize everything with this wonderful photograph that I stole from colleagues at Baycare Health in Tampa, Florida. Quickly, here's this house officer. He's precariously balanced between these two canoes, right? On your left is historical and current fee-for-service. I'm going to do what I was trained to do, and I know I do it well, despite no evidence to support that. And I'm going to do more of it because I've set a target income. Now, I know there's no practitioner like that at the U of R or Jefferson, but everywhere else, this is a big problem. Or I could jump in the canoe focused on value-based care. We coined a phrase, I'll review this in part 3, no outcome, no income, and we'll come back to that. So population health basically says, look, this guy has 3 choices. He could jump in the canoe, historical and current fee-for-service, and what he doesn't realize is 100 yards downriver is a 1,000-foot waterfall, and he is going to perish. And I think you could argue that the onesie and twosie practices who were crushed by COVID had to close. Thousands of primary care doctors either retired or went out of business because why? They weren't able to see people. Whereas the doctors who were in a value-based, managed care, capitated, bundled system, whatever you'd like to describe, who had a guaranteed income per patient per month, happily went on their way, did telemedicine, and survived. Now, I'm simplifying, but not too much. The third choice this guy could do, of course, is what's happening all over America with guys who graduated from medical school in 1981. They jump in the drink and call it a day. One more tuition payment, and I'm out of here. And into the water they go. So what's population health? Well, let me get to it by telling you a story. So the first time we heard the term population health, you got to go back to 2003. That's a long time ago. In an article by David Kindig, still alive and working at the University of Wisconsin in Madison, in a paper in a public health journal. And he says, public health is really important, but I have a new term, population health. And I'm going to define that for you in a moment, but I want you to see this map first. So this is a map of Philadelphia. And using data from the Robert Wood Johnson Foundation and work out of Virginia Commonwealth University, why it's in Virginia, but a map of Philadelphia, don't worry, but here's the data. My office is very close to the Center City and the Liberty Bell. I'm 3 blocks away. You'll have to come and visit. I showed you the picture of our beautiful building. So if you're lucky enough to be born in Society Hill, that's what we call that section of town, your life expectancy is 88 years. If you get in a taxi with me and you go up to Temple University's medical school, 5 miles away in North Philadelphia, your life expectancy pre-COVID is 68 years. 88 versus 68. So sure, I know what some of you are thinking, of course. That ghetto is a mess, has been for generations. That structural racism, redlining, lack of appropriate food, no place to exercise, no safe place for kids to play, that's not a COVID problem, that's an American problem. But COVID crushed these folks because now where were these kids going to get a meal if the schools were closed? And where were these people who don't have a paid day off? They had to go to work. So let me tell you another book story. So in the last 3 months, I've been grateful to go around the country. I'm at a beautiful event at a very exclusive club in Center City, Philadelphia, with very smart people. They're celebrating their contributions to science in our city. I won't tell you more. Fewer than 100 people in the audience. We're taking questions after a fireside chat about my book. A fellow raises his hand, says, Dr. Nash, I want to push back a little bit on you. You know that's not a good opening when someone's asking a question. And I said, what's that, sir? He said, well, those million dead, don't you think they mostly would have died anyway? Just think about that for a moment. So I said, well, Mr. So-and-so, the 365 SEPTA, that's our bus and train outfit, those 365 conductors who all died in the first 4 months of COVID, do you think they would have died anyway? Because they were essential. We had to have the subway running to get the nurses to Jefferson. We had to have the cooks open to cook the meals so the school buses could go outbound, not inbound, to bring the food to the kids who couldn't get to school. So I know that this touches all kinds of issues, most of which we're not going to resolve in one board presentation. But how could it be in our great country, 88 versus 68, pre-COVID? So now you add COVID to this, and it's a toxic situation. But the good news is that I think population health, this is the cover of the most important medical journal, USA Today. This is the 2017 article that I think started the public to understand. You mean if we could keep people out of the hospital, we could actually make them better and save money? Well, almost. It's a pretty simplistic view, but that's part of it. And here's the main message, and this is David Kindig's paper, as I noted a moment ago. We won't go through every detail, but what's the main message? Well, it turns out that this conceptual framework we call population health, first defined in 2003, pretty long time ago as it turns out, hence that's why we called our school population health, not public health, because it's all based on this piece. It turns out that there are certain contributors to health, you know this, and there's certain determinants, and we can measure those determinants. And here's the punchline message. It's not about, and here I am in the temple of technology, both here and in my day-to-day work for the last 33 years, has very little to do with what goes on in Strong Memorial Hospital or Thomas Jefferson University Hospital, and has all to do, as it turns out, with everything else that we've come to call the social determinants, or what Don Berwick calls the moral determinants of health, or what others simply call the determinants of health, which are all about, let's go back, those determinants are listed all here. Medical care, that's 15% of the story. Socioeconomic status, read their zip code, that's a big chunk of the story. Mom and dad, that's the genetics. The social, the environment, and the individual. You know, I can hear George Engel's voice, because I was lucky enough to have him as my small group leader, talking about the biopsychosocial model, which, trust me, 45 years ago, not too many people were talking about. So I think I had it in my blood from Rochester to then 45 years later, start thinking, well, there's got to be more in play here than just the $4 trillion of delivering the services. It has a lot to do with these other very uncomfortable issues like poverty and crime and alcoholism and racism. Who wants to talk about that at dinner? Or at least before 10 p.m. And what are we going to do to tackle all that? And so COVID sort of took population health. Remember, I told you it took me 2 years of explaining it every day at work. It shined a light on this. It put a rocket booster on our field. It put it on steroids, a big dose, because people said, you know, that population health stuff, that Nash guy, he's such a pain on our campus, nonstop talking about this. Maybe we ought to find out more. So in a way, you know, selfishly, amazing what happened to Charles and me, but it took a pandemic for folks to recognize stuff that had been going on for quite a long time. So the summary is, it's not about the delivery of the services. That's how we spend the money on the right. What really keeps us healthy is all that other stuff. But if you live in a high crime environment and you have no money, it's going to be awfully hard for you to have healthy behavior to keep yourself healthy. So the other challenge, and we talked a little about this with Evan Dawson, is this. First of all, don't you love this picture? I mean, this is pretty cool. So this is, of course, Michelangelo's David in the Uffizi Gallery in Florence. If you've never seen it up close, you know, it's mystical. But this is the American 2023 version of David. And here's the data. 40% of all women, and 30% of all men over 18 are obese in our great country right now. Was true pre-COVID, worse post-COVID because of being inside and being together all day and eating way too much and, oh my goodness, all the rest. So let me ask you one sort of epidemiologic question. And you'll notice this reference goes all the way back to 2006. The study's been repeated twice. Trust me, it's current data. I know it's crazy. So here's the question, and then we're going to ask the board chairwoman for the answer because she's the board chair. So Diana, what percentage of adult Americans do all 5 of these things right now, January of 2023? Exercise, don't smoke, eat their fruits and vegetables, wear a seatbelt, and we'll say are close to an appropriate body mass index. What percentage of adults do you think do this in Rochester, in Philadelphia? You name the city, just give me a percentage, please. What's your best sense?
15%.
Outstanding. The answer is 3%. 3%. So let me just reflect for Michael and Mark. Do you want to be at risk for a population with this sort of behavior, right? So that's what we're talking about when we're in an accountable care organization, when we accept a bundled payment, when we're capitated and we're responsible. So not only are you going to tackle all those social determinants, you're also going to tackle all of the behavioral issues. So more on that in a minute. So the good news is, I'm proud to tell you, we wrote the first textbook in population health. We have the only peer-reviewed journal coming out of our college. So now the best thing, I think, part of my selfish legacy is 15 colleges of population health now in America. Our book is in dozens of different schools, and most medical schools now have a department of either population health or global health or something pretty darn close to it. And in our lunch today with the wonderful medical students that I spent time with, they were very much in tune with this, knew the vocabulary, was spectacular. So the challenge, I think, that we're going to face, there are 2, and then we'll go to the last part of our time together. One challenge we're going to have here in Rochester, certainly in Philadelphia, is, well, how are we going to engage and work to improve the health of the population? That's really not what we're built to do. We're built to deliver acute and chronic services for the acute and chronically ill. We can't even agree on what the measures are to document our success. And this is one slide that shows you there are at least 5 measures, I know 10 more, that we'll have to figure out what's the best measure. Big topic for another time. Another topic is this, and we'll close part 2 with this story. In case you don't recognize it, this is a map of Pennsylvania. You know, it's like a big rectangle. Philadelphia is in the lower right in the county called PH. So this is, Pennsylvania has 67 counties. I grew up on Long Island in Nassau County. Now I live in Montgomery County in Pennsylvania. So we have 67 counties. And using that same data set that I showed you, the map of Philadelphia, this is the map of Pennsylvania. Using the same data, we were able to rank the health of the population in every county and rank them from 1 most healthy to 67 least healthy. So maybe now you've already figured it out that Philadelphia County, home of the 5 medical schools, home of the nation's first college of population health, is the least healthy county in the entire state. So if the mission of academic medicine is to improve the health of the public, Madam Chair, what grade would you give to the 5 medical schools in the county of Philadelphia? I won't ask you for an actual grade, but you get where I'm going with this. So what is population health, colleagues? Reconciling this mess. I mean, essentially, that's our mission. Okay, let's talk about the future. So I really like Malcolm Gladwell. If you've ever got to see him in person, he's kind of a tall string bean with a huge afro haircut, super energized guy. Lots of bestsellers. This, I still think, is his best book, The Tipping Point. So here's my question to the board. Are we at a tipping point, colleagues? Are you going to let 1 million dead? You're going to go back to your business just like you did before 1 million dead? That's my question. So let me show you what some of the options are. So you could call it value-based payment, population-based care. any number of synonyms. We could quibble. There's books written about every aspect of this. But you know that when it finally gets to be the cover of Medical Economics magazine, which is sort of to the right of Genghis Khan, you know, when it finally gets on Medical Economics, every kind of doctor is thinking about value-based payments, certainly when it gets to a cover story like make money off of population health. Let me show you, and you've seen slides like this, I'm sure. I'm going to show you 2 pictures. This is the strategy for the future. And just focus on the upper right here, because a high-performing place like U of R, like Jefferson, you're doing this, but I think the most important things you already sort of saw at the board meeting. Predictive modeling, managing utilization, optimize efficiency, improve the patient experience. I mean, you know this, we know this, but it's going to be gut-bustingly difficult, hard work. In a culture that's all about autonomy, stoicism, heroism, individual performance, teamwork, what's that? In an industry where we're going to have to change the culture of who we are and how we go about doing our daily work. That's what really value-based care in the end of the day is going to be about. And similar diagram to get us to global risk. Again, lots of synonyms, lots of jargon. Main point, are we doing the right thing to the right patient in the right way at the right time? And how are we going about doing it, and are we doing it safely? I mean, sounds corny, but that's the sort of cornerstone moving forward. And the cultural change necessary to do it, the closure of the feedback loop, gut-bustingly difficult work that folks, as I mentioned, Bob Panzer and I, to some extent, have been doing for 35 years. Telling experts that they could do a better job is not a wonderful activity. You know, Bob remembers when I was at Rochester, I was 6 feet, 2.5 inches tall. 33 years of telling doctors, you know, there's a better way. Let's figure it out together. That's dangerous work. So let's get to the last piece. Evan Dawson asked me a lot of questions about the Payvider chapter. We don't have time except to say that I think maybe one day, even in this marketplace, you'll get together with the principal payer, because after all, what do we really want? We want a healthy population. And instead of your great outcome of we have successfully renegotiated our Blue Cross contract, same true in Philadelphia, maybe a better outcome might be we've successfully created a joint venture where we're going to experiment together and put money at risk to actually improve health and measure what we do in the community. And we're going to take that disparity and inclusion conversation and drive it to actually improve quality and have measures of how we're doing that in the community. And maybe we'll do what Omar Sharif, my colleague Sharif at Rush University System for Health, and David Ansel in the same New England Journal of article not 2 weeks ago talked about hiring everybody from the community as a part of the way to be a responsible citizen. I'm not advocating one versus another, but I hope you'll take a look at some of what's going on around the country to engage in this Payvider experiment. Okay, so last 5 minutes. This is not at Rochester, certainly not at Jefferson, but in America's average 350-bed community hospital, this is the president of the medical staff. And this is a boy deer, not a girl deer. So why are they a deer in the headlights? Well, you know the old adage, you know, how'd they get to be the president of the medical staff? 2 ways. It's their turn, or better way, they missed 3 MEC meetings in a row, so they got appointed president for next year. That's the typical qualifications. So let's talk about the future. So details for this, not at this hour. I'm standing between you and adult libation. So the challenge is, colleagues and I at Jefferson, we're looking at the creation, the growth rather, of 2 new industries. A value-based care industry, and I'll just show you what some of the companies who are out there, many of whom you're probably talking to or potentially doing business with, and a social determinant of health industry. So we have documented these evolution now of two distinct industries funded, as I already noted, by private equity and venture capital, who are in the business to say, we'll help you figure this out. We'll help you to be efficient and slim down costs and get care into the home. We'll help you to do that. I'm not advocating that as the strategy, but I just cataloging that we're trying to do the research evidence to say what exactly is going on out there and why is it that that 1 trillion of waste that attracts, like sharks if you would, so many companies from the outside world, outside of our industry, focused on trying to make a buck doing this right. Maybe they've got something worth listening to. Okay, let's wrap this up. Summary, major themes moving forward. 1918 all over again, colleagues. Transparency and accountability. If we can't do that, shame on us. We're spending the public's money. For board members, I feel your pain. As I said, after 2 decades of doing that, you are spending the public's money. I hope you take it seriously. 50 cents of every dollar of the 4 trillion comes from Uncle Sam, and you're the stewards of that money. Hard-earned, tax-supported money. If you believe the experts, the Medicare Trust Fund, if we do nothing different, will be bankrupt in 2027. That is not far from now. So we need a new plan, and that's the charge. So transparency and accountability, and no outcome, no income. Lots of people have said, well, that's not enough transparency. We got to go beyond 1918. This is Steve Shortell's most recent work. Details for you not important, except to say, very smart people, Peter Pronovost, Steve Shortell, Bob Wachter, other giants in our field are saying we need an SEC-like organization to compel hospital boards to be transparent and accountable. Madam Chair, you don't want this. Trust me. But it could come our way if we're not good stewards of the money that we're spending. So the equity conversation I'm going to save for when I have a glass of wine. It's an incredibly complex problem, one that America has an awfully hard time getting its arms around. I get it. When I sat in a room like this, down the hall, from 1977 to 1981, there was not a single person of color, and there were 9 women out of the 90, the largest number of women the school had ever accepted. We've made a lot of progress. We got a lot more work to do. And it's not just about diversity and inclusion. That's important. That's window dressing. The real work is going to be when we connect excess spending because of disparity and inequality? And the answer to that is, of course we can. Of course we can. Because that'll get the attention of the people who have the power to make a difference. Much more on that at another time. So we got to change the culture. Raise your hand if you love to change culture. I don't see anybody doing that. Okay, so let's wrap up. Got to practice based on the evidence. Well, we know that. We have to find it. We have to reduce unexplained clinical variation. Incredibly hard to do. Only way to do that is gather all the data and close the feedback loop. Incredibly tough job. I know you know this. Most of it started here. Pretty incredible. Reduce slavish adherence to professional autonomy, a fancy way of saying, I know I'm right. Just watch me. Continuously measure and close that feedback loop and engage with patients as partners across the entire continuum. Incredibly tough for us to do. These are some of the things that are on my list. There's hope. I mean, there's great burgeoning literature on how to reduce burnout, practices that have done it. It's not about giving you a muffin when you walk in the morning. Honest to God, that's happened. It's about, do you have an opportunity to get leadership training? Can you write a prescription for a patient for food, for rent, for legal help? That seems to limit doctor, nurse, and pharmacy burnout. Are there resources in the community that you've organized to help people? That seems to contribute to markedly reducing burnout. So The Surgeon General, Vivek Murthy, is all over this. Maybe you're aware of his most recent report right before Christmas. Is going to be a national policy effort to tackle well-being. You guys, the students, we saw it today, the medical students have a dog, right? Service dog that they can visit and pet. I wish I had that in 1978 when I was flunking genetics. Maybe it would have helped, right? Okay. So let me leave you with this. At the end of the day, it's all about leadership. You guys are blessed, truly blessed that you have great leadership. It will not last forever. So the challenge is, today, you got to build the leaders for tomorrow. That's the real challenge. And you're incredibly lucky that you made it to this point in time. You survived COVID. You set a great national example, as did Jefferson. The structural challenges, they're there. We're going to have to do a lot of work as a country. Will you let 1 million dead go by? You know, we talked about this, Evan Dawson and me. When the dying stops, the forgetting begins. I hope you won't forget. That's the key. So part of it is leadership training, up and down the line. With the medical students at lunch, we talked all about this. There's all kinds of things. Jefferson led a consortium and stimulated, in no part by my experience with Bob Panzer and many others. There are now 15 master's degrees in quality and safety in American graduate schools. No one could have foretold that gut-bustingly difficult hard work to build the first one at Northwestern, the second one at Jefferson, and 13 more, and now we're working together to self-evaluate, to look in the mirror, to build a curriculum, to certify and accredit these schools. This is the legacy for leadership for the future. So let me leave you with my final slide, and that's one of my academic heroes, John Cotter, of course, at Harvard Business School. And Madam Chair, I want to say thank you again for having me, and Dr. Taubman, that the institutionalization of leadership training is one of the key attributes of good leadership. Translation, of course, to build the leaders of tomorrow, you got to start today. And that's one of your top priorities. So in closing, thank you again for having me. Mark, I really appreciate your gracious invitation. All the revenue from our book is going to go to Jefferson. I hope you'll tell your family members all about it. And I just hope in closing that we'll be able to have a conversation in our great country about all these issues so that 1 million people didn't die in vain. Thank you. I'm willing to take 1 or 2 questions. Yep.
Yeah, I think we have time for a few questions.
And I want to just remind everybody, their questions are standing between us and alcohol.
That should shorten it.
That should shorten it. Yeah. Okay, I know we also are open. We have folks on the line. All right, let's start with here in the audience. We'll do 1 or 2 and 1 or 2 online. We don't have any. Okay, very good. And when you have the microphone, just please, the courtesy, your name and who you represent or where you're from, please.
Well, excellent talk. My name's Jim Gate. I'm a family doc in a rural, underserved area, solo practitioner, another dying breed. I much appreciate your insight and input, but when I look at the preamble of the Unaffordable Care Act, which talked about standardization and simplification, and I also look at when we spend 5 cents out of every dollar on primary care,
right,
it's very hard to re-engage and change course in population health.
Impossible.
I'm putting out fires with gasoline.
Yep.
How do we get patients to buy into this? This is a new paradigm for them who are used to coming in, getting their acute problems taken care of,
right,
let alone their chronic problems managed, and doing it in an affordable way. When we have an insurance model that puts people one illness and one paycheck away from poverty.
Right. So all great questions. I thought you were going down and everybody could hear his question and because of the microphone. So great question. I thought you were going down the road of where I would agree that we need a different kind of primary care doctor and many more of them with a different skill set, most especially the teamwork attribute. You know, patient engagement, gigantic topic, of course. I have to go back to the education process. I mean, how much energy have we spent on behavioral economics, exercise physiology, addiction, understanding? I mean, all the things that drive behavior that leads people to have acute and chronic illnesses. I mean, I didn't show you the mortality data, but I mean, you could, you know, right now at Strong, at Jefferson, obesity, alcoholism, drug abuse, all the downstream effects of all of that, that's what the hospital is filled with, right? So the economic model is based in part on all of that. So rewarding people to stay healthy, well, that's an important part of realigning the economic incentives, as you're well aware. Engaging patients, I'm hopeful that some of the new technology will help an awful lot. That's also a Band-Aid. It's got to start in school where appropriate, in an environment where we have governors who won't let certain AP courses be taught in high school because it doesn't fit his political views. Trying to put healthy eating and exercise in the curriculum is going to be awfully hard. So, you know, maybe it's a region by region basis, maybe it's state by state. I don't have the answer. Only in America, if you live in a red state, you are less healthy than if you live in a blue state. That is nonsense. No other free country has that. So, you know, sir, I feel your pain. I think the primary care piece is the most important piece, and we've got to lick that, and it's awfully way past the time to appreciate that in some of these newer payment systems, the primary care doctors are actually doing extremely well getting people well. And that is a remarkable thing in the disruptive primary care practices, some of which you know all about. I suggested at dinner that we're going to come to a time, at least at Jefferson, where we can't ignore Oak Street and Absolute Care and Care One and all the rest. And we'll have to find a way to have residency programs with those organizations as one step towards the future. Great question. Anybody else in the audience? Yes, sir, all the way in the back. And again, just please tell me who you are and where you're from.
Hi, Simeon Bannister with the Community Foundation and a board member here at the Medical Center. I will just upfront admit to a lack of depth of knowledge in this area, but I am curious how much you know about what's happening in New York. What I understand is that in this state, at least for the last 6 or 7 years, there's been a shift to the model that you described that focuses on value-based payments.
Right.
I'm curious to hear you opine on the implementation of that model in this state and what's working it out.
Yeah, well, certainly your leadership knows all about this. If you look, you know, nationally, we're at somewhere around 10 to 15 cents of every dollar at economic risk. That's not going to get us to the goal line, if you would. On the other hand, you know, Medicare's public goal is 80+% of all beneficiaries in some kind of risk system by 2030. Well, you know, these two seem disconnected in my view. Again, I think, you know, healthcare is largely local. There are pockets both in New York and certainly in Pennsylvania and Philadelphia in particular where they're already close to that 80% at-risk goal. In multi-specialty group practices, let's put it this way. Let me step back to sort of give you the national view. So who's the largest employer of doctors in America? Do you know the answer, sir? So it's United Healthcare, a Fortune 5 company headquartered in Minnetonka, Minnesota. This all happened in the last decade. So what do they know that we don't? Well, they know that if they own the means of production, they'll reduce variation, they'll cull the herd to follow their rules, and they'll drive utilization down, efficiency up, and they'll make a buck doing it. And they're going to do it with doctors who they sign their paycheck. Now, I'm not advocating that that's the only way, but, you know, it's a model that seems to be working pretty darn well for United Healthcare, with profits that soared during COVID, most especially, because of lower utilization. So I just think it's time for organizations like mine, especially, to say maybe the historical way we're going about doing this is not going to get us to the goal we all want. And different models, different arrangements, the payvider, different partners, all the social determinant and value-based care companies. There's a lot out there. I don't know the answer. I think there's multiple answers to get us there. But to answer your question about New York State, well, the national average is 10 to 15 cents on the dollar. That won't get us there. And in this market, based on what I learned today about Excelis, you're not even at that level. You're in a very traditional payer-provider marketplace, at least for now, right? But that's Excelis. Uncle Sam has a different view. Uncle Sam, under both Republican and Democrats, CMS knows there will be no future without connecting it to the payment to the outcome. Of that, I'm pretty confident. It's a great question. Let's do one more if we have anybody online. No one online. Outstanding. We'll do one more from the audience. Yes, sir. Again, tell me who you are, please, and where you're from.
Impressive presentation. Thank you very much. I'm Roberto Hernandez. I am Chief of Transplantation here at the University of Rochester.
Wonderful.
And part of this board member. I just want to know, you're mentioning that the area around Temple, the survival, it's around 62 years old compared to the area in the center that is 86.
Right.
What are the top 2, 3 things that Jefferson is doing to change that?
Yes, that Jefferson is doing to change what's outside the doors of Temple. Yeah, great question. A modest amount at the moment. We have the Center for Health Equity that's both got internal funding, philanthropy, and grant money. Like many places, we now have a Chief Equity and Diversity Officer, a black female OBGYN full professor with a huge staff. We're training community health workers. Those are the issues that we're tackling, right? Yeah. That's a great question. I mean, my challenge was, well, if we believe that improving health of the population is part of the mission, then we need to do more. And how we go about that, I think, again, one of my models is West Side United with Rush in Chicago, but that took them 15 years to build. So we're a little bit behind in trying to catch up to them. And I hope we'll be able to do activity like that. Great. Well, colleagues, once again, thank you so much. I really, really appreciate it. Thanks again.
Thank you so much. I appreciate it very much. Thank you so much, Dr. Nash. A truly outstanding presentation.